So, very good evening to everyone. Today, we'll be discussing all the important topics related to your previous year questions, which has been asked in the exams. So, we are discussing community medicine. I'm Dr. Rajeev Shetty. So, let us go topic chapter wise, which are important for your exams. So, the first and foremost thing which are important for your exams is questions related to vaccines. So the first and foremost thing you should know is National Immunization Schedule. So there are questions on vaccination schedule for you. So at birth, we are giving BCG, OPV 0 dose and hepatitis B. Hepatitis B birth dose to be given within 24 hours. Remember this, within 24 hours. After that, 6, 10 and 14 weeks, we are having important vaccines, OPV and pentavalent. All the states they are using OPV and pentavalent. So OPV first dose, second dose, third dose. Pentavalent first, second and third dose. Pentavalent in all the states now. Along with that, we are having rest in peace. What is rest in peace? RIP, Rota, IPV, PCV. Rota, IPV, PCV, pneumococcal conjugate vaccine. So in this Rota, 3 doses at 6, 10, 14 weeks. IPV, 2 doses at 6 and 14 weeks. And PCV, 2 doses at 6 and 14 weeks. These 3 vaccines are used only in selected states, not all the states. Remember this. Pentavalent all the states, but these 3 vaccines, what I call it as rest in peace, only in selected states. 9th month, very important for a child. Measles first dose or MR first dose. Most of the states they are using MR now. What is MR? Measles, rubella. First dose at 9th month. Vitamin A along with this vaccine. Japanese encephalitis only in endemic states. Only in endemic states. PCV booster at 9th month. They'll ask this question. PCV booster at 9th month. What is one more addition to this? IPV. 3 doses. Yes, the third dose at 9th month. Repeat how many doses of IPV now? 3. Fractional IPV means it is given intradermal. We give it in right deltoid. So we are not using full dose IPV. We are using fractional IPV in the schedule. 16 to 24 month, when the child crossed 1 year, we are supposed to give booster doses. DPT first booster, OPV booster. Along with this, measles second dose or MR second dose. Most of the states they have shifted to MR. So you should remember MR how many doses? 2 doses. First dose at 9th month, second dose at 16 to 24 months. Japanese encephalitis second dose at 16 to 24 months. Keep this remember when is MR second dose given in the national schedule. So how many doses of MR? Measles, rubella? There are 2 doses. There are 2 doses. Good. So again come to this 5 to 6 years we are giving DPT second booster. So it is DPT, not pentavalent. It is DPT, not pentavalent. Pentavalent within 1 year. So how many doses of DPT boosters we have? First dose and second dose. TD vaccine is used in adolescents. Before we had TT vaccine, tetanus toxoid. Now we are using TD vaccine. First dose at 10 year, second dose at 16 years. Keep this in mind. First dose at 10 year, second dose at 16 years. What we have in pregnancy, again it is TD vaccine, not TT. TD vaccine 2 doses at a gap of 4 weeks. First dose and second dose. First dose as early as possible during the first antenatal visit. Second dose at a gap of 4 weeks. If the pregnancy happens within 3 years, if she was vaccinated before, she has to take only booster. Underline this number. Within 3 years, if she conceives again, she has to take 1 dose of TD booster. So this is National Immunization Schedule. So we are discussing all the important topics in a rapid, concise mode. This is one short session for FMGE exams. So based on the foreign medical graduate exams topics which has been discussed in my subject community medicine, I'll be discussing all the important topics. One was National Vaccination Schedule. Very, very important. They can ask any question out of this. You should mark it correctly. The second thing what you should know is vaccine related adverse effects. Repeatedly asked question, vaccine related adverse effects. BCG can cause three things: suppurative lymphadenitis, BCG osteitis, and disseminated BCG infection, which can cause symptoms similar to tuberculosis. The symptoms almost similar to tuberculosis, disseminated BCG infection. The time limit for disseminated BCG infection can be asked, that is between 1 to 12 months. After taking BCG vaccine, this side effect can happen between what time limit? If they are asking, it is between 1 to 12 months. Out of three side effects in which we have to start ATT. ATT has to be given in second and third side effect. Anti-tubercular therapy we have to give in second and third side effect, but systemic ATT is not necessary in suppurative lymphadenitis. Not necessary in suppurative lymphadenitis. Measles or MR, what are the side effects related to this? Febrile seizure, thrombocytopenia, we call it as immune thrombocytopenic purpura, ITP, immune thrombocytopenic purpura, remember this. Encephalopathy and toxic shock syndrome, if there is contaminated vials. Toxic shock syndrome can happen in measles very much frequently compared to BCG vaccine. Oral polio vaccine can cause VAP. This is one side effect related to OPV. Any child who is having congenital immunodeficiency, any child with congenital immunodeficiency can present with paralysis after receiving OPV. OPV is a live attenuated vaccine. It can cause paralysis only in congenital immunodeficiency. The time limit is being asked in the exam, that is 4 to 30 days. Note down this. After receiving OPV, the paralysis can happen between 4 to 30 days. 4 to 30 days. Whole cell pertussis, which is a part of DPT vaccine. Nowadays, we are using mainly acellular pertussis, but whole cell pertussis, when it is used, it is neurotoxic. It can cause symptoms similar to pertussis component, which is neurotoxic. Inconsolable screaming, seizures, that is febrile seizures, hypotonic hyporesponsive episode, highlight this. Hypotonic hyporesponsive episode is not a contraindication for future doses. Note this point, it is not a contraindication. Encephalopathy, all these are side effects. The only contraindication for pertussis component will be active seizures, active epilepsy, or even encephalopathy. These two things are contraindication. What I am showing in the slide is side effects related to whole cell pertussis, which is a part of DPT vaccine. Good. How to reduce these side effects? By using acellular pertussis. Acellular pertussis, or you can omit pertussis component. That is the way to reduce all these side effects related to whole cell pertussis of DPT. Tetanus, toxoid or TD vaccine, side effect brachial neuritis. Rotavac, repeatedly asked question, intersusception. Intersusception. Rotavac, side effect is also intersusception. At the same time, contraindication is also intersusception. Any child with an history of abdominal surgery, Rotavac is contraindicated. They will mention a child with an history of abdominal surgery, what vaccine is contraindicated? Your answer will be Rotavac. Influenza killed vaccine. Don't make mistake. Influenza, there are two types of vaccine, live and killed. Live vaccine is given intranasally. The side effect can be wheezing, but killed vaccine, which is present with influenza related thing, it can cause Guillain-Barré syndrome. Repeatedly asked question, killed influenza vaccine can cause Guillain-Barré syndrome, and yellow fever, which is 17D strain, can cause symptoms similar to yellow fever. We call it as vaccine associated viscerotropic disease. It is liver failure, hepatic failure symptoms can happen, jaundice, and the patient can present with multi-organ failure. That is vaccine associated viscerotropic disease. Don't make mistake. Vaccine associated paralytic polio is due to oral polio vaccine, but vaccine associated viscerotropic disease is due to 17D yellow fever vaccine. What is the strain of yellow fever used? vaccine used, that is 17D. So these tables, side effects, either they can ask direct one-liners, or they can make it massive following, or they can give a clinical scenario for you. In the clinical scenario, it will be a paragraph question. Take your time, they'll use so many keywords in the question, and the answer what you're marking will be based on this table. So we have discussed one national immunization schedule, and the second one is side effects of vaccine and how the side effects will happen, and what are the time limits. What are the time limits? That is also very, very important. So the third thing which is important for you is open vial policy. So highlight this point, open vial policy. What I am doing, if I'm opening a vial, half used vials, they can be used in the next sessions also. For how many days? Once I mention date and time, so how many weeks you can use it? It is 28 days. 28 days means 4 weeks. So 4 weeks of time is there. So once you mention date and time, you can use it in the next session. For how many days? 28 days. So for that purpose, expiry date should not has been passed. Cold chain condition should be appropriate. Vaccine vial septum is not submerged, or if it is submerged, it is contaminated. Aseptic techniques to be followed. At the same time, VVM should be intact. VVM should be in stage 1 and 2. If it is 3 and 4, we are discarding it. So always keep all these points in your mind. One is VVM should be intact, and the second thing is that all the other conditions like expiry date, there is no contamination, all these things are fulfilled, then you can use half used vials in the next session. So as you are using in the next session, the purpose is to reduce vaccine wastage. But this open vial policy is not applicable to what vials? BCG, measles or MR, JE, and Covishield and Covaxin. For Rotavac, it was not applicable before, but now it is applicable. Rotavac can be used in the next sessions. Now, whatever the newer stock of Rotavac is coming, those vaccines can be used in the next sessions. So, all the other vaccines other than BCG, MR, GE, or COVID related vaccines, other than this, all the other vaccines can be used in the next session. Now, if I'm asking this question, if there is half used pentavalent vaccine, date and time is mentioned, will you use it in the next session or not? Answer my question good. Will you use half used pentavalent vaccine in the next session or not? If this is the question, answer is correct. But what you will do if it is MR or measles vaccine? You will not use it, you will discard it. You will not use it, you will discard it. What is this policy called as? Very good. To reduce vaccine wastage, what is this policy called as? Open vial policy to reduce vaccine wastage. Good. Come to next part. After vaccines, you should know few questions on indicators, morbidity indicators and mortality indicators. These two topics are very, very important. Health indicators related. One is morbidity indicator, the other will be mortality indicators. Morbidity indicator, write down, one is incidence, the other is prevalence. Incidence and prevalence. New cases which happens within a time limit, that is incidence. Once you come across this word, incidence means which happen in the future. It is not existing thing. It is new cases which is happening in the future. New cases with respect to time. So you need follow. You should start with the population at risk. Then you have to follow for certain duration. After certain duration, like half 1 year or 2 year, you will get new cases. That study where you do follow, that study where you're doing follow-up is called as cohort study. Cohort study we do follow. Once we are keeping follow-up or duration, that new cases what is happening in the system is called as incidence. That is why it is told it is rate. Incidence is rate of new cases with respect to time. So once you give time, once you do follow up with respect to time you are doing, and that is called as incidental finding, incidence. Denominator is population at risk. Means if I want to check how many will develop hypertension, I have to take only at risk of developing hypertension. Already having hypertension will be excluded. Baseline screening will be done. Already having hypertension will be excluded from the study. Only those who are at risk of developing hypertension in the future, means they are not having hypertension, they'll be included under the study. It depends on the duration of illness. No, incidence will not depend on duration of illness. Prevalence later I will tell, that depends on duration of illness. Used to study cause to effect relationship, correct? That is called as temporal association. Starting from risk factor, you are checking how many will develop disease in the future. If I start from smoking, how many will develop lung cancer in the future? That sequence is important when you do a cohort study. That is done only in cohort study. That sequence is called as temporal association. It is the most important criteria. Temporality is the most important criteria to prove etiological hypothesis. I have to start with risk factor. I have to give some time. After 1 or 2 years, how many will develop disease? That is what I am checking. Risk factor to disease concept. That sequence is called as temporal association. Temporality is proved from follow-up studies like cohort study. That is the reason why incidence is a better measure for etiological hypothesis, not prevalence. If they ask what is the reason, temporal association present, temporality, temporal association present. Proved in what study? Cohort study. Cohort study where you're doing follow-up, it is the amount of risk what you are checking, the risk of developing disease, because you are starting from risk factor going towards the outcome. You can tell this is the culprit for disease to develop. Etiology, risk, causation, all these are synonyms. Etiology, risk, causation, all these are synonyms. So what is that association which is important? And that is proved in cohort study called as temporality, temporal association. So it will help to determine risk factors for occurrence of disease. So what are the risk factors? How much role they play? Like these questions, if they are asking to determine risk factors for developing disease, or cause to effect relationship, temporality, cohort, all these are important points related to incidence, not prevalence. So prevalence is existing cases at one point of time. When you go and do a study at this point of time, you are going to a class and checking how many are having obesity, how many are having diabetes. That is no follow-up. So there is no follow-up in such studies to estimate prevalence. Prevalence is present tense. How many are having disease is prevalence. How many will develop disease is incidence. So present tense, the study what is being done is called as cross-sectional study, not follow-up. It is at one point of time, cross-sectional study. Cross-sectional studies will do follow-up, true or false, false statement. There is no follow-up in cross-section. It is just the amount of disease, like out of 100, 50 are having disease. You are just using a pie chart, proportion of diseased individuals, cross-sectional study, total population will be included. Prevalence depends on duration of illness also. What is that equation in the classes what you have discussed? P is equal to I into D. Prevalence depends on two factors, incidence and duration of illness. If the duration is more, prevalence is more. Chronic diseases will be having more prevalence. Acute diseases will be having less prevalence. That is what they want to say. Chronic disease, long-standing disease present, you'll be counting them in the cross-sectional study. Prevalence will be very high, but acute illness duration is short, you will not be counting them, so prevalence will be lesser. Prevalence will be more for chronic disease. If they ask prevalence depends on duration of illness, so answer is true statement. So it is used to study etiological hypothesis? No. Since there is no follow-up, cross-section cannot be used for etiological hypothesis. Cross-sectional study cannot be used for etiological hypothesis. Keep this in mind. It can be used for etiological hypothesis. Answer is wrong. It cannot be used for etiological hypothesis. Indicating burden of disease, answer is correct, because prevalence says how many are having disease, not how many will develop disease. How many will develop disease is incidence, but how many are having disease, that is burden. Prevalence indicates risk, no. Prevalence indicates burden, and at the same time telling how widespread is the disease. All these are synonyms. Burden, widespread. But if I'm telling risk, causation, etiology, the other side it will go. Risk, causation, etiology, all these are terms which will go in favor of incidence, but prevalence, present tense, cross-sectional study, no follow-up, not etiological hypothesis, only for burden. So these things are important. At the same time, don't forget this equation. Prevalence depends on incidence into duration, duration of illness. Mortality indicators. In the previous slide, what we discussed was morbidity indicators. Here it is mortality indicators. So in this session, I'm trying to make it more concise in a rapid revision mode. The purpose of this session is not understanding it. The main purpose is for revision, what we are keeping. So all the topics which has been covered in your regular batches or FMGE sessions, we have to make it concise so that the revision part is important for you. So it's a rapid revision what we are doing. It is one short session. What we had done for NEET, now the same thing is being done for you also. Very useful sessions. Just keep on noting all the things which I'm telling there. Mortality indicator, crude death rate, crude death rate. Denominator, mid-year population. In the whole population, what is the risk of death you are counting? So it is not age or sex specific. Age wise and sex wise mortality you are not counting. You are telling the whole population what is the risk of death. If I make it specific, age wise and sex wise, that becomes specific death rates. Age specific death rate and sex specific death rate. Within this age group, how many are dying? Within males, what is the risk of death? Within females, what is the risk of death? That is totally different thing. Crude is the whole entity for the whole population, but age-wise and sex-wise, you are just bifurcating things. You are taking different subgroups within this age group, within this sex. So the question is, if I am telling risk of death in the whole population, that is crude death rate. Crude death rate. If I am telling one more important point, if I am telling this question, risk of death in different subgroups, risk of death in different subgroups. If the question is on different subgroups, the question is on different subgroups, then your answer will be specific death rate. So crude death rate and specific death rate, इसमें थोड़ा फर्क है. So no, crude is for the whole population. Crude is for the whole population, but specific death rate is for subgroups. Specific death rate is for subgroups. So subgroups, either it is age wise or sex wise. Either it is age wise or sex wise. Proportional mortality rate means out of the total entity, denominator is deaths due to all the causes. Denominator is deaths due to all the causes, but numerator will tell deaths due to a disease. If I want to know the contribution of tuberculosis, numerator is deaths due to tuberculosis. Denominator is total deaths due to all the causes. Denominator is total deaths due to all the causes. If they are telling the contribution, if I want to know, then we are using proportional mortality rate. What is the denominator? Deaths due to all the causes. What is the numerator? Deaths due to certain diseases. So that will indicate the burden of that disease with respect to mortality, means what is the contribution, burden of that disease with respect to mortality. At the same time, it will tell the magnitude of that disease. Magnitude means contribution of that disease for total amount of deaths. So burden of disease, or if they are telling magnitude of preventable mortality, or if they say to know the most common cause of death, which disease is contributing more, to know the most common cause of death. All these points, if it is written, it is going in favor of proportional mortality rate. So what is the denominator? Total deaths. Don't make mistake between proportional mortality rate and case fatality rate. Case fatality rate is denominator cases, numerator death. How many will die? Like 100 cases, 100 will die. Fatality is 100%. 100 cases, 50 will die. Fatality is 50%. Case fatality rate will indicate how many are dying. The denominator will be total number of cases. So this will indicate virulence or killing power of a disease, not burden. What is the burden indicator for mortality? If I'm asking, which is the mortality indicator for burden? Proportional mortality rate. But what is the indicator to suggest killing power of a disease or virulence? If I'm asking, case fatality rate. So don't make mistake in these two things. And two more things which are repeated for you in the exams, a bit of extra adds question. If you mark it correctly, it is good. A bit of extra adds question. One is age standardized death rates. How it is done, calculation part not necessary, because most of the calculation related difficult calculations will not be asked in the exams. Only thing what they're asking is the purpose. Two populations with different age structure, two populations with different age structure. One is old age population, the other is young age population. Two populations are there. If I want to compare the mortality pattern, if I want to compare the mortality pattern in such situations, what you are using, the question is direct. The answer is age standardized death rates. How it is calculated? Direct standardization. Age standardized death rates is calculated from direct standardization. So what is the standardization done for age standardized death rates? If I'm asking, it is direct standardization. What is the purpose of age standardized death rates? Two populations if you are comparing with different age structure, standardized mortality ratio. Standardized mortality ratio. What is the use of this? It is used to compare the mortality pattern between occupation and general population. For example, working in coal mines, coal miners, asbestos workers, whether they are having more risk of death or less risk of death compared to the general population, so that if they are dying more, we have to give incentives, we have to give proper insurance coverage for them. If that is the situation, if you're doing, then what mortality indicator is used? Comparing mortality pattern between in occupation and general population. What is your answer? Standardized mortality ratio. Standardized mortality ratio. How it is calculated? From indirect standardization. Again, I'm telling standardization calculation part is totally different. That is an undergraduate exercise what we are giving for MBBS students. But competitive exams, they won't ask calculations of standardization, but they will ask what is being done, what is the way to calculate age standardized death rates, direct standardization. What is the way to calculate standardized mortality ratio, indirect standardization, and the formula for standardized mortality ratio can be asked. Observed deaths in that occupation divided by expected deaths. Observed deaths in that occupation, like coal miners, how many are dying? Divided by expected deaths. Expected deaths means what will be the mortality pattern in the general population. Such situation we are doing indirect standardization. Now tell me one by one. 1, 2, 3, 4, 5. Crude death rate used for the whole population. Specific death rate for subgroups. Proportional mortality rate burden. Case fatality rate virulence. Standardized death rates for populations with different age structure, and standardized mortality ratio for comparing the mortality pattern between an occupation and general population. Occupation and general population. Keep this in mind. These are some important questions. So we have covered indicators, one mortality, and the previous slide we have discussed morbidity indicators. Morbidity indicators. Come to the third one important slide in indicators part, that is index. Human Development Index, Physical Quality of Life Index, Multi-Dimensional Poverty Index, and Global Hunger Index. Any question can come out of this, important. Within Human Development Index, there are three things you should know. One is knowledge, income, and longevity. We take the mnemonic kill: knowledge, income, and longevity. What is the knowledge in that country? Either measured in terms of two things: mean years of schooling and expected years of schooling. On an average, mean years of schooling, and depending on the dropout rate, expected years of schooling. Literacy rate is not considered. Literacy rate is not considered. Income is taken, yes, it is GNI, gross national income, not just GDP. It is GNI and life expectancy from birth. So overall, when you take the mean, Human Development Index is geometric mean of all the three dimensions. It is geometric mean of all the three dimensions what you're checking, and you are comparing the standard of living between two countries. Human Development Index is used to compare what, if I'm asking, it is standard of living. When they ask country 1, country 2, if I want to compare the standard of living, what index is used? Your answer should be HDI, Human Development Index. What is used to compare quality of life? What is used to compare quality of life? Your answer should be PQLI. Don't make mistake. Standard of living considers income. Income is included in HDI. Quality of life will not consider income. It is subjective well-being what you are checking. So in this, IMR, literacy rate, and life expectancy at age 1. Income is not considered. Keep this in mind. Income is not included in PQLI. It is infant mortality rate, literacy rate, and life expectancy at age 1. So we can take the mnemonic ILL: infant mortality rate, literacy rate, and life expectancy at age 1. Life expectancy at age 1. Because IMR is separately given importance, so it is life expectancy at age 1 what you are counting. So what is the mnemonic? Kill ill. We have a movie na, kill ill, like that. You can remember it like this. It is kill ill. Kill ill. Important. I for infant mortality rate, not income. Comparing the poverty status between countries. Comparing the poverty status between countries, we have to use multi-dimensional poverty index. Before we had human poverty index, now we are not having human poverty index. What we are supposed to use? Multi-dimensional poverty index. How many dimension? 1, 2, 3. Health, education, living standards. Remember the mnemonic HEL. Health, education, living standards. Within health, we are having two indicators: child mortality and nutrition status. Not infant, it is child mortality and nutritional status. Education, we have years of schooling and school attendance rate. Years of schooling and school attendance rate, and living standards: cooking fuel, water, toilet, electricity, floor, and assets. Sir, is it possible to remember all these things within multi-dimensional poverty index? Yes, they are checking your memory. Some factual based questions what they are putting will check your memory, not just the concept. How many dimensions? 3 dimensions. How many indicators? Total 10 indicators are there. This was the question. 2 things in health, 2 things in education, 6 things in living standards. So total 10 indicators are used in multi-dimensional poverty index. So keep this in mind. How many indicators in MDPI? Total 10. But how many dimensions you are checking? How many dimensions you are checking? You are checking 3 dimensions. What is the mnemonic? Health, education, and living standards. So repeat three letters in sequence for me. Kill, ill, hell. Kill, ill, hell. Kill is for HDI, ill is for PQLI, and hell is for poverty. Multi-dimensional poverty index. Good. Global hunger index, important thing. There are 3 things to be considered. 1, 2, 3, 4. Means there are 4 indicators to be included. I'm not checking about the dimension, I'm telling the indicators for you. 4 indicators. First indicator is proportion of undernourished population. Proportion of undernourished population, 1. Second, under 5 wasting and under 5 stunting. What you're doing is within the 5 years, within under 5 means within 5 years you're checking wasting and stunting. Wasting will indicate acute malnutrition. Stunting will indicate chronic malnutrition. So keep these two things in mind. Both acute and chronic malnutrition will be considered. At the same time, mortality pattern under 5 deaths is also counted. So it is more of children oriented index. Hunger index will reflect a more on children. So that is what they are counting. And global hunger index of India is 29.1 indicating severe hunger. 29.1 indicating severe hunger. If they ask it is mild, moderate, severe, it is under severe hunger. Global hunger index. So important. Tell me 1, 2, 3, 4. Repeat with me. Good. Human development index, physical quality of life index, multi-dimensional poverty index, and global hunger index. Very important topic. And coming to some questions on infectious disease epidemiology, some terms will be asked for you. Like we have started with vaccine, second week finished indicators. Now this topic infectious disease epidemiology, some repeated questions I'm asking for you. Natural history of disease is best studied by cohort study because follow-up is done. Starting from risk factor, disease and complication, that sequence of disease is natural history. That is studied by cohort study, not RCT. RCT is not used. Intervention is not done. Cohort where intervention is not done is preferred for natural history of disease. Level of prevention in pre-pathogenesis phase. Pre-pathogenesis phase and pathogenesis phase. Natural history has two phases, pre-pathogenesis and pathogenesis. Pre-pathogenesis risk factor is already present, like you are exposed to the agent. Epidemiological triad present in pre-pathogenesis phase. Agent, host, environment is interacting. Agent, host, environment is interacting. You have to take precaution. Risk factor is already present. Primary level of prevention. You can take vaccine. You can use masking. All this specific protection measure, what you're doing is under primary level of prevention. But pathogenesis phase, that is the next phase where symptoms will come, complications will happen. Pathogenesis phase, secondary and tertiary levels of prevention can be done. So what is done in primary level is done in which phase? Pre-pathogenesis phase. Secondary and tertiary levels is done in pathogenesis phase. Ability of an agent to produce clinical illness, pathogenicity. What is happening? There are three words: infectivity, pathogenicity, and virulence. IPV. Infectivity, pathogenicity, and virulence. Infectivity is an ability of an agent to invade and multiply in the host. If I am telling these words, invasion and multiplication in the host, that is infectivity. Producing clinical illness, pathogenicity. Producing death, fatalities, that is virulence. Repeat my words: invasion and multiplication, infectivity; illness, pathogenicity; deaths or fatalities, that is virulence. Serial interval means it is the gap between primary case and secondary case. Primary case and secondary case. That gap is nothing but incubation period of that disease. If I want to know the incubation period, you have to take the average of serial intervals. This is the question: how to know the incubation period of a disease? Take the average of serial intervals. An estimate to express communicability of a disease within the family, closed contacts. If I want to check communicability, we are using secondary attack rate of that disease. How much communicable within the closed group. But if I want to know the rate of spread in the whole population, important, we have basic reproduction number, expected number of cases generated by one case in a population where all the individuals are susceptible to infection, means a new disease. Like for example, COVID, everyone was susceptible. In order to check the rate of transmission in the community for a disease which is new to the population, how much, like one case can produce 2 cases or one case can produce 3 cases, that depending on the disease. If one case is producing 10 cases on an average, basic reproduction number will be 10. If one case is producing 2 cases, basic reproduction number will be 2, like that. That is indicating rate of spread, rate of transmission in the community for a new disease where everyone is susceptible, to that disease. Hidden portion of an iceberg will not include healthy population. Remember, iceberg phenomenon is commenting on illness which is detected and illness which is not detected. That line of separation is between apparent and inapparent illness. Illness which is easy to detect, illness which is not detected. Illness not detected will come under submerged portion like latent infection, carriers, subclinical infection will come. So it has nothing to do with healthy population. Carriers of e-virulent organisms is called as pseudo carriers. Remember two terms which are repeated in your exams. One is paradoxical carrier, the other is pseudo carrier. Paradoxical carrier is a carrier got infection from one more carrier. A carrier developed disease and it got infection from one more carrier, that is paradoxical carrier. But carriers of avirulent organisms, something atypical avirulent organisms, that is called as pseudo carriers. Irregular and haphazard frequency of cases is sporadic. Scattered distribution is known as sporadic. What is excess frequency of cases called as epidemic? Usual frequency of cases endemic. If I am telling irregular frequency of cases, that is sporadic. Epidemos means in excess, unusual frequency. Endemos is within usual frequency. Sporadic is scattered distribution of cases. Cyclical trend in measles. Usually what is happening in measles, herd immunity will come down. Cyclical trend means if there is an outbreak now, after 3 years there is one more outbreak. There is a gap of 3 years, then after 3 years there is one more outbreak. This thing which is happening, cycles for a disease, can happen in measles mainly due to susceptibles which can increase. Susceptibles will increase because of changes in herd immunity. This is the question. Changes in herd immunity can lead to what variation in measles? Your answer will be cyclical trend. Cyclical trend. Good. Come to next important topics, that is study designs related thing. They'll ask so many questions on case control study and cohort study for you. Repeated topics, either they will put a question on case control study or cohort study, but most of the exams will be having two topics together. There can be 2 to 3 questions in a paper on case control study and cohort study. You should know these two study designs properly. What is case control study? As the word suggests, it is cases versus control. Healthy individuals will take, that is control, and you will take diseased individuals. So cases versus controls you are comparing. You are comparing what? Exposure. How many are smokers in cases? How many are smokers in controls? You are comparing the exposure pattern between cases and controls. If the exposure is more in cases, odds ratio what you calculate will be more than 1. If the exposure is more in controls, odds ratio will be less than 1. More than one positive association risk factor, less than one negative association protective factor. This is how you infer the strength of association. Strength of association in a case control study is given by odds ratio. More than one positive association, less than one negative association. Good. So what you are doing, you are checking the exposure pattern in cases and controls. That is why the study is not going in a forward direction. The study is going in a backward direction, retrospective study. Starting from effect, going towards the cause, effect to cause. Because starting with cases and controls, you are asking their past history. History of smoking, history of alcohol. That is why you are taking the risk factor. You are going from effect to cause, means you are asking exposure pattern. The study is retrospective, easy to conduct, inexpensive because there is no follow-up. Cohort study where you do follow up, it is very difficult to conduct, you need time and cost. But case control study, no need to worry about time and cost. If I don't have time, if I want to know the strength of association, what studies to be done, if they're asking case control study, very less number of subjects and you can study multiple exposure for a disease. You are studying lung cancer disease, You can ask so many exposures: exposure to smoking, asbestos, beryllium. These things, multiple exposure can be studied because the study pattern is retrospective. Since you are asking the exposure pattern, you can ask multiple exposures and case control study. And rare disease, don't do cohort study. If I want to know the association of rare diseases, never ever commit cohort study. Cohort study will take time, money from you. If the disease is rare, after doing follow-up, if you are not getting anything, you are wasting your time and cost. That is why rare disease association, if I want to check what study is preferred, it is case control study. Recall bias can be seen because the studies between diseased and non-diseased individuals, you are asking the history of exposure. Already having disease will make them to think more because they're emotionally down. They'll think more compared to healthy individuals. That excess of recall in one group compared to one more group, that is called as recall bias. Recall bias is seen in what studies? Repeat my words: case control study, not cohort study. Cases versus controls, if you're comparing, you're taking the history of exposure pattern, the deceased individual will be thinking more and they'll be recalling more. The study is retrospective study. Recall bias can happen. Odds ratio is used to study the strength of association. Come to cohort study, completely opposite pattern. Here you are going completely opposite direction, is prospective. Most of the cohort studies, what we are doing is prospective. Very few cohort studies where you use records, that is retrospective cohort study using records. The study pattern is from risk factor to outcome, cause to effect, cause to effect. So risk factor to the disease, cause to effect. You divide them into two groups: exposed and non-exposed. If I'm taking smokers and non-smokers, or if I'm taking alcoholics and non-alcoholics, and if I'm doing follow-up, after certain duration, what is the outcome? So the study is going in a forward direction. So it is time consuming study and costlier. If I'm asking which is time consuming, which is causing money, like from the pocket I'm putting because of follow-up of 10 years, 20 years, if I want to study, answer is prospective. Cohort study will take time and cost. Large number of subjects we need because dropouts can happen in between. Since there is dropouts, we call it as attrition bias. Loss to follow, loss to follow. Attrition bias, since it is present in cohort study, dropouts can happen in cohort study. That is the reason why we need to take more number of individuals in the study. We need to take more number of individuals in the study. So multiple outcomes you can study. The reason is follow-up is being done. Since you are doing follow-up, multiple outcomes can be studied. Like if I start with smokers, smokers can develop lung cancer, bladder cancer, esophageal cancer. Like that, I can study the multiple outcomes. Once you're doing follow-up, then only we can study multiple outcomes. But multiple exposures can be studied in case control study. Multiple outcomes are being studied in cohort study. Loss to follow-up is seen in which study? Cohort. Recall bias is seen in case control. Rare disease, case control is suitable, cohort is not suitable. But in cohort study when I'm doing, to know the strength of association, we calculate risk ratio, also known as relative risk. What is the strength of association in a case control study? It is odds ratio, but in a cohort study, it is risk ratio. What is one more name for risk ratio? Relative risk. What is the formula for risk ratio? Cohort study, we have risk ratio. Yes, good. What is the formula for risk ratio? Incidence in exposed group divided by incidence in non-exposed group. Correct. Incidence in exposed group divided by incidence in non-exposed group. This is the formula for risk ratio. Risk in smokers divided by risk in non-smokers. Risk in exposed group divided by risk in non-exposed group. That is the formula. Risk ratio is obtained only when you do follow-up. Only when you do follow-up. Come to this important topic. Next, one more important topic, that is they will ask some questions on sensitivity and specificity. Most of the times, if they want to make it difficult, they can ask PPV and PV for you. So especially for FMGE exams, I'm telling, they'll ask more of sensitivity, specificity, screening exams. And if they're asking, or if they want to make the paper difficult, they'll ask PPV and NPV. So listen now, patients with bowel cancer. Patients with bowel cancer, that is the reality. Disease present, absent. Disease present, absent. For example, endoscopy. What is happening with this? If the procedure what you're doing is invasive initially, that is the gold standard, fine. But if it is invasive, you have to go for a screening test. Screening test, like occult blood test, what you are checking. It is not invasive, not uncomfortable for the patient also. How much it will detect and how much it will not detect. That is what you are checking. Like for example, total 30, out of 30, 20 are identified. 20 true positives. Out of 30 individuals with disease, 20 are identified. This is sensitivity of a test. 20 by 30. What is the definition of sensitivity? Ability of a test to detect true positives. Ability of a test to detect true positives. If 20 are identified, remaining 10 not detected. Remaining 10 not detected. So that result what the test is giving is not correct. Negative result by mistake. So we call it as false negative result. If sensitivity is high, false negativity will be less. A high sensitive test will have less false negative result. That is what I wanted to convey. A high sensitive test will have less false negative results. Come to the other side. Total around 2000 are normal individuals. In that, true negative result you have to count how much it is being detected. So numerator 1820 true negative result, total 2000 normal individuals. This is specificity of a test. Ability of a test to detect true negatives is specificity, but ability of a test to detect true positives is sensitivity. If true negatives in this box, but the remaining individuals, even though they are normal, you are labeling them as positive, false positive result. So test with less amount of specificity will have more false positive result. A high specific test is being done to reduce false positive result. If the test results are less specific, there can be more false positive result. So repeat my words, sensitivity and false negatives, they go opposite. Specificity and false positives, they go opposite. Keep this in mind. At the same time, total test positives, how much? 200. In that, how many are having disease? 20. You're going in rows, that is positive predictive value. Total test positives, 200. How many are having disease? 20. So it is very less. 10% is the positive predictive value. In the same way, total test negatives, the denominator, how many are normal in the numerator, that is negative predictive value. So when the table is given for you, always remember in columns when I am doing it is sensitivity and specificity. When I am coming in columns, it is sensitivity and specificity. Same thing you are catching and going in rows. This is PPV, NPV. Positive predictive value and negative predictive value. See here, it is clearly mentioned. It is clearly mentioned for you. When you are going in rows, sensitivity, specificity. Columns, sensitivity, specificity. Rows, it is PPV, NPV. So column 1, sensitivity. Column 2, specificity. Row 1, PPV. Row 2, NPV. Keep this in mind, important. when they ask you to calculate predictive values, we have to go in rows. Row 1 PPV, row 2 NPV. Statistics, one more important topic, that is tests of significance. I don't want to miss this topic in this rapid revision session which I am doing, because I have seen some papers where one question is important and it will be asked. Sometimes if they want to make it more important this topic, they might ask two questions from the same table. Tests of significance is very important topic. Mean values, if I am comparing, it is parametric tests. Parametric test. So repeat my words. Parametric test is used to compare the mean difference between the groups. Two groups, if I am comparing, student t-test, also called as unpaired t-test. What is one more name for student t-test? Unpaired t-test means two groups you are comparing. One group was given treatment, the other group was given placebo. Comparing the mean hemoglobin levels. What is the impact of the treatment on the mean hemoglobin level of group 1 or placebo when it is given for group 2? Comparing mean values between two groups, student t-test. Mean values for more than two groups. If I am giving treatment A, treatment B and placebo, three groups are there. Comparing the mean cholesterol levels or mean hemoglobin levels or mean systolic blood pressure levels by using three groups of patients. Mean value, then ANOVA test, analysis of variance. One group before intervention, after intervention. If I am taking a group of diabetics now, mean blood sugar I am checking. After lifestyle modification for 6 months, what is the mean blood sugar in that group? Mean I am checking. One group before, after intervention. What test? Paired t-test. Paired t-test. So there are three things to be remembered. One is student t-test. Second is ANOVA test. Third is paired t-test. Remember the mnemonic SAP. Student t-test, ANOVA test and paired t-test. All these are parametric tests of significance. Comparing proportions, non-parametric tests. Non-parametric test. Proportions usually asked in the exams, two or more than two groups, chi-square test, one group before after intervention, McNamara test. Comparing cure rates, treatment A, treatment B. Treatment A 80%, treatment B 20%. Proportions you are comparing, proportion of success rates, proportion of cure rates between group 1, group 2 or group 1, group 2, group 3. Such situation we are using chi-square test. Chi-square test is used to compare proportions, not mean. Two or more than two groups, chi-square test, or one group you are taking. Prevalence of obesity was 10%. After intervention, prevalence of obesity decreased to 5%. One group of school children, prevalence of obesity 10%. After intervention, it decreased to 5%. Proportion before, after you are doing. One group, McNamara test. McNamara test of significance. So there are two things to be compared. One is chi-square test, the other is McNamara test. Remember the mnemonic CM, Chief Minister, is used to compare proportions. Association, if you are checking, either you can do case control study or cohort study. Either you can do a case control study or cohort study. Association, if you are checking, you have to use and do chi-square test of association. So what is the test to check the significance of association? Chi-square test. So parametric test, there are three things. Non-parametric test, there are five things actually. Chi-square and McNamara for proportions. Remaining three tests. Like if I am telling remaining three tests, I am writing here Mann-Whitney test, Mann-Whitney test, Kruskal-Wallis test, Kruskal-Wallis test, and Wilcoxon sign rank test. Wilcoxon sign rank test. So there are three more tests which can be used for comparing median values. Mann-Whitney test for median between two groups, Kruskal-Wallis median more than two groups, and median one group before after Wilcoxon sign rank test. So these tests are used to compare median values. That means non-parametric test total 5, chi-square, McNemar for proportions, and the remaining 3 for median. These things can be used to compare proportions and median values. So come to one more important one-liners in statistics which can be asked for you. Any skewed data, outlier present in the data, don't use mean. Mean is not preferred. Use median. Not affected by outliers in the data because it is a central value of an ordered data. Once you arrange the data in order, if you are taking the central value, that is median. So that is why median is preferred for skewed data. Mean is the most affected measure of central tendency. Mean is affected by outliers. Skewed data don't use mean. Random sampling means like you are booking lottery chits will have equal and known chance of selection. Don't make mistakes in the exam. What you think, it's like Pulja Sim Sim, what you're thinking. Out of 100 chits, if you're picking 10 chits, all are having equal 10% chance of selection. If I pick 20 chits, all are having equal 20% chance of selection. The word probability indicates known chance of selection depending on the number of chits what you are picking, not unknown chance. It is equal and known chance of selection. Non-homogeneous groups, like for example in a population of 100, 70 girls, 30 boys are there. 70 girls, 30 boys are there. It is non-homogeneous structure. Non-homogeneous population, simple random sampling should not be used. Simple random sampling should not be used. Divide them into two groups. Divide them into two groups. From 70 select 7, from 30 select 3. Two groups and randomly you are picking. This is called as stratified random sampling. What is strata? Strata means groups, what you are dividing. This will ensure proper or equal chance of selection or proper representation. From 70 if you are picking 7, from 30 if you are picking 3, there is proper representation. So what is this type of sampling methodology called as stratified random sampling? And two groups are there, like for example comparing the variation of two variables. So for example in males, if I am checking two variables, pulse and blood pressure, pulse and blood pressure. What is the amount of variation in pulse and blood pressure? Pulse unit is different, blood pressure units will be different, but still comparing the amount of variation between two variables with two different units, whether pulse will show more variation or BP will show more variation in males. In such situation, what is used for comparing the variation? Don't make mistake, repeatedly ask question. Answer is coefficient of variation. Coefficient of variation is used to compare the amount of variation. Next, relationship between two quantitative variables. Relationship between two quantitative variables like height and weight. Both are quantitative variables. The strength of relationship is given by correlation coefficient. The relationship is called as correlation. The strength of correlation is given by correlation coefficient. And important point is this is represented by scatter diagram. So scatter diagram is also called as correlation diagram, and scatter diagram is used to represent correlation. What is correlation? Ka definition: strength of relationship between two quantitative data, that is height and weight. And again, if I want to know the amount of variation in a dependent variable, you have to make an equation y is equal to a plus b into x, where x is independent variable, y is dependent variable. For example, x is salt intake, y is blood pressure. Increase in salt intake will increase how much amount of blood pressure? The amount of variation in the dependent variable with respect to independent variable, that is studied only by using regression. Regression software will give, and the answer is coefficient of regression. If they ask question in diabetics patients, if age is increased by 1 year, what is the impact on blood pressure? What is the amount of change in blood pressure with respect to age? That is given by coefficient of regression. So don't confuse between three coefficients. Repeat 1, 2, 3. One is coefficient of variation, amount of variation between two variables when measured in two different units. Next, strength of relationship between two quantitative data, scatter diagram, positive correlation, negative correlation, what you'll be showing. That is given by correlation coefficient. Image is scatter diagram, and impact of change in y, like if I'm changing x by 1 unit, salt intake is increased by 1 gram, 2 gram, 3 gram per day. What is the amount of change in y? That is blood pressure, given by coefficient of regression. Regression will predict the change in y with respect to x. So these are some important questions on statistics, tests of significance, and all the points which I have discussed there. Skewed data, median, probability, equal and known chance, stratified random sampling asked most of the times, coefficient of variation, correlation coefficient, and coefficient of regression. Don't make mistakes in these things. Come to one more important topic in communicable diseases, that is emerging infections. When the words emerging infection comes, the word emerging infection comes, they'll ask so many questions on new infection like CCHF. What is CCHF? Crimean Congo hemorrhagic fever. The reservoir will be cattle and camels. Crimean Congo hemorrhagic fever, reservoir cattle and camel. Vector is heart tick. So bite of ticks can lead to viral hemorrhagic fever. Fever, joint pain, bleeding. Case fatality is 10 to 40%. This is CCHF. What is the vector of CCHF? Heart tick. Ebola fever, reservoir is fruit bats. Exposure to bats can lead to important manifestation: fever, joint pain, internal bleeding. Mainly the patient will die due to multi-organ failure, that is internal bleeding. Rule out yellow fever, rule out dengue. Where there is internal bleeding and death, exposure to bats, that is Ebola fever. Bats to man through secretions, man to man it can go through body fluids. Fatality is around 50%. Nipah, again exposure to fruit bats, but there is acute encephalitis. Case fatality is more, around 60%. On an average we tell it as 60%. Now tell exposure to bats and bleeding, Ebola. After exposure to bats, there is acute encephalitis. Acute encephalitis. Don't make mistake. Bats and bleeding is Ebola. Bats and encephalitis is Nipah. Don't make mistake in between these two things. Zika, hemorrhagic fever. Aedes will be the vector. Any Aedes bite can lead to fever, rash, conjunctivitis. Rule out Zika. Problem with Zika is pregnancy. If she is infected, that can lead to microcephaly among newborns. Microcephaly is the risk factor. That is the problem that can lead to morbid conditions in the population. Zika is transmitted through which vector? Aedes. Anti-hemorrhagic fever, exposure to rats, especially rodent feces and urine. Rodent feces and urine leading to two R's: respiratory failure, renal failure. Almost similar to leptospirosis, but that is more of hepatic symptoms and kidney oriented symptoms in leptospirosis. But here it is respiratory failure and renal failure. If they ask questions after exposure to rodents, rodent feces leading to respiratory failure, when these two words come, RR, rodents and respiratory failure, your answer is going in favor of Hanta. Keep this in mind. Good. MERS, Middle East Respiratory Syndrome, exposure to camel. When you develop respiratory, that to acute onset of respiratory failure, not chronic, it is acute onset. MERS, Middle East Respiratory Syndrome, also known as Saudi SARS. Almost symptoms similar to SARS, severe acute respiratory syndrome, but affecting Middle East countries. Exposure to camel. Then once the patient is affected, he will go and transmit the infection in the community. Droplet mode is seen. MERS will be transmitted through body fluids, no, rarely, but it is mainly through droplets. Middle East Respiratory Syndrome, what is the reservoir? camel. This table is very, very important. Emerging infections nowadays trending topic. Come to program part, important updates. I'll be discussing in alphabet mode, whichever is important for you. Abhiyan Indradhanush is sanitation in ESI hospitals by giving colored bed sheets. Every day they'll change the color of the bed sheets in Webgar pattern. That will promote sanitation since they're changing the bed sheet every day. Abhiyan Indradhanush is different from Mission Indradhanush. Abhiyan Indradhanush is sanitation, ESI hospitals, bed sheets. Mission Indradhanush is vaccination schedule. Don't make mistake between Abhiyan Indradhanush and Mission Indradhanush. Ayushman Bharat scheme has two components. One is health and wellness centers. All the primary health centers and sub centers will be transformed into health and wellness centers, giving comprehensive primary care. Allopathy, along with allopathy, Ayush modalities will also be included in the treatment part. That is comprehensive primary care. Pradhan Mantri Jan Arogya Yojana is one more component under Ayushman Bharat. What they are doing, health insurance is given up to 5 lakh per family per year. So every year they are insured for 5 lakh rupees. That is Pradhan Mantri Jan Arogya Yojana. These two are components under Ayushman Bharat. Antara is an injectable contraceptive given intramuscular, that is PMPA, hydroxyprogesterone acetone based contraceptive. ERT in HIV patients, now it is TLD. Don't make mistake, not TLE, it is TLD. Tenofovir, lamivudine and dolutegravir. So it is in alphabet mode what I am telling. If all these are important alphabets, A related question. Come to C, Chaya pills. These are non-steroidal OCPs, oral contraceptive pills. That is Centroman. Before it was coming under the brand name of Saheli. Now it is Centroman. C for Centroman, C for Chaya. Keep this in mind. Centroman and Chaya. Even is an electronic vaccine intelligence network where you enter the data related to vaccine stocks and cold chain temperature. That is a mobile based application. Data entry is being done to monitor the vaccine stocks and cold chain temperature. ESI benefits you should know. Sickness benefit 91 days, extended sickness 2 years, and maternity benefit 26 weeks. These three things are repeatedly asked. Sickness benefit 91 days, extended sickness for chronic diseases 2 years, and maternity benefit is for how many weeks? 26 weeks for confinement. Next alphabet, important update, free days. These are sanitary pads given to rural adolescent girls. Asha workers will distribute sanitary pads to rural adolescent girls under the brand name Free Days. This is menstrual hygiene scheme to promote menstrual hygiene. Mission Indradhanush, it is vaccines related schedules what we are following in our country. Indradhanush mode. Previously 7 diseases was covered. Now we are covering 12 vaccine preventable diseases. Keep this in mind. It has been extended to 12. Childhood TB, BCG can prevent. Diphtheria, pertussis, tetanus, PPT. Polio, OPV, and IPV is also there in the schedule. Hepatitis B, pneumonia, meningitis, important. Meningitis can be prevented by Hib vaccine. Hib is a part of pentavalent. Measles, rubella, and GE rotavirus diarrhea. So total 12 vaccine preventable diseases under Mission Indradhanush. INAP, Indian Newborn Action Plan. Indian Newborn Action Plan targets single digit we need to achieve. Single digit neonatal mortality rate and single digit stillbirth rate. So it is single digit by the year 2030. So at a country level, national level, we have to achieve single digit of neonatal mortality rate and stillbirth rate by the year 2030. INEP for adolescents. What is INEP? Intensified National Iron Plus Initiative. Anemia Mukt Bharat. Janani Shishu Suraksha Karyakram will give free services. A pregnant will get two things: JSY cash, JSSK free services. Don't make mistake in between these two things. Cash is given under JSY. Free services for pregnant and sick infants is given under Janani Shishu Suraksha Karyakram. Kayakalp initiative is to promote sanitation in public health hospitals. all the government hospitals, the internal and the external. Hygiene, public health facilities means hygiene is important. That hygienic conditions, sanitation is maintained or given by which initiative? It is Kayakalp initiative. For maintaining proper quality and hygienic conditions, Kayakalp awards are also being given. Kayakalp awards are also being given. Lakshya scheme is to promote labor room quality. Monica project is to check the risk factors for cardiovascular diseases. It is a WHO project to know the trends and risk factors for cardiovascular diseases. Midday meal scheme, school children midday meal, it is under Ministry of Education now. Previously it was Ministry of Human Resource Development, but now it is under Ministry of Education. Again, midday meal should include what? 1/3 of calories and half of protein requirement for a child. This is the thing in midday meal quality checking is important. 1/3 of calories and half of protein requirement. Navjat Shishu Suraksha Karyakram to train doctors for basic newborn care and resuscitation. Don't make mistake between other programs. Navjat Shishu Suraksha Karyakram is training doctors for basic newborn care and resuscitation to reduce neonatal mortality. So the training is being given for hypothermia, infection, and also asphyxia. That point is missing here, asphyxia. So all these are things which are important under Navjat Shishu Suraksha Karyakram. Niksha is a website for online notification of TB. TB is a notifiable disease in India. Notified through which website? If they are asking, it is Nikshay. Kshay Roga means tuberculosis. So Nikshay is a website for TB notification. Suman scheme. Surakshit Matritva Ashwasan. Suman scheme, what they are doing, they are giving free services, but they are making sure that the service will be reaching the beneficiaries. Every hospital they are mentioning a notice board, they are mentioning the guarantee charter, service guarantee charter is mentioned, what is the menu, what are the services to be given in this hospital. At the same time, once you are mentioning the charter, if the services are not given, they are giving one number, call center, grievance redressal mechanism. Call center number is given so that if the complaints is registered, that will be called zero tolerance policy. Zero tolerance policy is one of the important component of Suman scheme. Suman scheme. And Sparsh campaign is to create awareness for which disease? Sparsh campaign is to create awareness for which disease? Answer is leprosy. So leprosy awareness, if I want to create at the community level, we are having one scheme that is called as Sparsh. Sparsh campaign. Good. Fertility indicators. In the previous parts, initially when I discussed the indicators, we have discussed mortality indicator and morbidity indicators. Now what we are discussing is fertility indicators. Crude birth rate, number of live births per 1,000 mid-year population. So it is mid-year population in the denominator. Live births divided by mid-year population in the denominator. But if I change the denominator to reproductive women, live births divided by reproductive women into 1,000, that becomes general fertility rate. Number of live births per 1,000 women of reproductive age group, that is general fertility rate. Total fertility rate is, on an average, one woman will have how many children? Keeping in mind age specific fertility rates. So it is indicating family size of that population. One woman will have how many children on an average, keeping in account only age specific fertility rates, not mortality. It will indicate family size of that population. Gross reproductive rate count only girls. Total fertility rate count both, but gross reproductive rate count only girls and women will have. Net reproductive rate is very, very important. Number of girls a newborn will have in the future. Since I am starting with newborn girl and I am checking how many girls she will have in the future, both mortality pattern and morbidity pattern is considered. Since I have to start from a newborn girl, what is the mortality pattern of females in that population? And what is the fertility pattern in that population? This indicator includes both fertility and mortality pattern. That is why it is the best indicator of fertility. Which indicators count both fertility and mortality pattern in the population? Answer is NRR. So it is both fertility and mortality what you are counting. That is why NRR is the best indicator of fertility. If I say NRR of 1, what does it mean? NRR of 1 means one girl is replaced by one more female. One girl, when she is going out, she is donating one more female. That means she is getting replaced. So it is replacement level of fertility. NRR 1 is indicating that she is being replaced by one more, replacement level of fertility. If NRR is less than 1, population is below replacement. Important. Couple protection rate means how many are using contraceptives in the population, indicating contraceptive practice. If everyone is using contraception, prevalence is 100%. If half are using, prevalence of contraception is 50%, like that. Couple protection rate will indicate prevalence of contraceptive practice. So if I am saying if couple protection rate of our country is 60%, that is enough to achieve NRR of 1. In order to achieve a net reproductive rate of 1, couple protection rate should be how much? This is the question. Couple protection rate should be 60%. If that is the number which is being targeted in our country, every country the value can be different. For our country, based on this study, to achieve replacement level of fertility, NRR of 1, couple protection rate should be how much? Your answer will be 60% and above. Good. So total 5 fertility indicators which are important. Repeat my words. Crude birth rate for the whole population. General fertility rate, denominator is reproductive women. Total fertility rate means children. Gross G, girls. N, net, newborn girl. Number of girls a newborn girl will have in the future. Nutrition related questions. Vitamins and deficiencies, very, very important. Vitamin B1, beriberi, and Wernicke's encephalopathy. Beriberi, two types, dry, wet. Dry beriberi can present with peripheral neuropathy. Wet beriberi can present with congestive cardiac failure. Wernicke's encephalopathy is seen in chronic alcoholics. B2, angular stomatitis and cheilitis. B3, pellagra, niacin, diarrhea, dermatitis and dementia. Dermatitis, casus necklace. Around the neck, photoexposed parts, there is excoriation. Cereals responsible, maize and jowar. Maize, because there is lack of tryptophan. Jowar, there is pellagra because it is rich in leucine. Excess of leucine will block the conversion from tryptophan to niacin. That is the reason why there is pellagra in consumption of jowar. B5, pantothenic acid, burning feet syndrome. B6, peripheral neuropathy. Isoniazid for TB treatment can lead to B6 deficiency. Important. B9, megaloblastic anemia, deficiency can cause. B12, peripheral neuropathy. At the same time, pernicious anemia. Don't confuse between vitamin E and K. Vitamin E, antioxidant, the deficiency can cause hemolytic anemia of newborn. Vitamin K, the deficiency can cause hemorrhagic disease of newborn. K is important for clotting factor synthesis. A newborn gut bacterial flora is not mature. There is less amount of vitamin K synthesized. That is why there is bleeding manifestation. How to prevent? Vitamin K1 injection at birth. Vitamin K1 injection at birth is done to prevent what disease? If I am asking, it is hemorrhagic disease of newborn. Important vitamin deficiencies. One more important thing what they are asking for even nutrition is adulteration, toxicant related questions. Laterism, that is neurolaterism is due to consumption of kesar dal. Lathyrus sativus. Don't make mistake, it is Lathyrus sativus. Lathyrus odoratus is different. Lathyrus odoratus can cause odoratism, osteolatherism, but Lathyrus sativus can cause neurolatherism presenting with spasticity. One stick, two stick, three sticks. Later, they need crawlers to walk. They cannot walk from place to place. They need crawlers. The toxin is beta oxalyl aminoalanine. Beta oxalyl aminoalanine will be the toxin responsible for neurolatherism. Prevention part, vitamin C prophylaxis is used to prevent neurolatherism. At the same time, steeping and parboiling. Steeping and parboiling, these are food processing techniques used to remove BOA. What is BOA? Beta oxalyl aminoalanine. Epidemic dropsy. Argemone is added to mustard. Adulterant is argemone. Toxin is sanguinarine. Consumption can lead to pedal edema, cardiac failure, and glaucomas. Cardiac failure, pedal edemas, if they frame a question like this, it is epidemic dropsy. Argemone is an adulterant that should not be added. Shopkeepers will be adding in small amounts. Food safety is important. Food inspectors will go and detect. Nitric acid test is most commonly done test. Nitric acid test is most commonly done test. But if I am asking which is the most sensitive test, paper chromatographic test. So if they are adding in small amounts, if I want to detect argemone, nitric acid test is not sufficient. I have to go for PCT. What is PCT? Paper chromatographic test, most sensitive test. Endemic ascites is due to Crotalaria seeds, also known as Junjunia seeds in certain states. These are weeds actually. They will mix with other grains. Consuming them can lead to hepatotoxicity. They are having alkaloids, pyrrolizidine alkaloids. These are hepatotoxic, leading to jaundice and ascites. Jaundice and ascites. So the prevention part is de-weeding. Separate them and consume. Don't mix with other grains. So you always make mistake between epidemic dropsy and endemic ascites. Don't make mistake. Both are different. Aflatoxicosis is due to storage fungus, which is like when you store groundnuts in the moisture, that black fungus which accumulates on that is aspergillus. Aspergillus is storage fungus. Hepatotoxicity present. Aflatoxins are hepatotoxic. There will be hepatocellular carcinomas also. These are carcinogenic. How to reduce this amount? By avoiding moisture. Storage conditions should be proper. Ergotism, there are two types, acute and chronic. Because of claviceps purpura, which is accumulated on bajra seeds. Bajra, when you are growing on the field, it is field fungus. Some black fungus are accumulating. If you are consuming that, initially there will be nausea, vomiting. But later, long-standing consumption can lead to vasoconstriction, Raynaud's phenomenon, pain, tingling, numbness, all these things will happen. That is chronic ergotism. Chronic ergotism. So chronicity, chronic ergotism, how to separate that fungus? If I'm asking, it is floating in salt water. Salt flotation technique. Float in salt water so that the fungus will separate. 20% salt water is important. So how much amount of salt water is important for prevention? It is 20% salt water. Salt flotation technique is used to prevent ergotism. True statement, very important. Don't confuse with one more E. Ergotism. Sir, when I'm reading adulteration, I'll get confused within the topic. So I'm making it more concise for you. I'm giving a table clearly written disease, toxin, adulteration, prevention. This is how you have to make it topic concise and becomes easy for you for revision also. Chronic ergotism can present with, repeat, yes, vasoconstriction, tingling, numbness, sensation in the feet. INP, one more nutrition related topic. Anemia Mukt Bharat. Age-wise supplementation is must. You should know. 6 months to 5 years. Bi-weekly supplementation. 6 months to 5 years bi-weekly supplementation. 1 ml syrup is used. IFA syrup, how much? 1 ml. What is the dose of 1 ml? 20, 100. Don't make mistake. 1 ml, that supplementation dose is 20 mg elemental iron, 100 microgram folic acid. 5 to 10 years, we are using pink color tablets. Dose 45 400. Dose 45 400. Adolescents, blue color tablets. Dose 6500. Blue color tablet, dose 6500. Within school, we call it as WIFS. What is the full form? Weekly iron folic acid supplementation. Outside schools, we are giving only for girls. Anganwadi centers, we are targeting only for girls. Pregnancy, don't make mistake. Pregnancy, don't make mistake. So important thing for pregnant, it is daily iron folic acid. Daily iron folic acid. So the dose 6500 red color tablets. 6500 red color tablets. Right from second trimester. Starting from second trimester, 6 months. After delivery, 6 months. So total supplementation is 6 plus 6. 6 months, 6 months. So total 6 months during pregnancy, 6 months after pregnancy. So the duration is 180 days, 180 days. What is the color of the tablet? Red. Dose 6500, 6500. Reproductive women 20 to 49 years will be given weekly once red color tablet. Reproductive women for INP supplementation age group is different. It is 20 to 49. So we are giving weekly once red color tablets. So don't make mistake between pregnant and reproductive women. Pregnancy it is daily from second trimester. Reproductive women weekly once red color tablet. And reproductive women will separately get periconceptional folic acid. Around conception they will be given folic acid to reduce neural tube defects. Periconceptional folic acids to reduce neural tube defects. So the last 2 slides for you. We are going chapter wise and we are covering important topics related to this in 1 hour 95 minute session. Total 2 hours max. Silicosis, it is pneumoconiosis. Pneumoconiosis most common. Seen in mica minors. Seen in mica minors. So when they ask mica minors will be affected with silicosis. Yes, the dust is very important, silica, which is being exposed. And always silicosis will be the risk factor for tuberculosis. Any patient with silicosis in the future, he may develop tuberculosis. So the prevention part is dust control. They'll be wearing all the respirators, they'll be wearing the mask. The purpose is to avoid dust. And silicosis is notifiable disease under Factory Act. Important, silicosis is notifiable disease under Factory Act. So which is the most common pneumoconiosis? Silicosis. But if I am asking which is the most dangerous pneumoconiosis? The most dangerous pneumoconiosis, it is asbestosis. Asbestos usage can lead to mesothelioma. Asbestos, we are having types in that chrysolite, crocodylite. There are different types of asbestos. Crocodylite type is blue asbestos. Blue asbestos under amphibole type. This is having highest risk for mesotheliomas. So which asbestos is having highest risk for mesothelioma? It is blue asbestos. We call it as crocodylite type of asbestos. Asbestos is used in what type of industries? Cement, glass, and fireproof textiles. Fireproof textiles. And it can also be used in shipyards. So if they mention shipyards, cement, glass, fireproof textiles, all these are going in favor of asbestos related illness, mainly affecting lungs, mesothelioma of pleura. Coal miners anthracosis, coal miners anthracosis, cotton mills, textile mills, exposure to cotton dust, ricinosis. Cotton mills, textile mills, exposure to cotton dust, ricinosis. So who are affected more? Cotton spinners or weavers? Cotton spinners are affected more compared to weavers. The reason is when you separate fibers from the seeds, the dust is more. So spinners, they make this work of separating dust from fibers. So when they separate, the dust is more bicynosis, cotton spinners are affected more. Don't confuse bicynosis with bagasosis. You make mistake between two B's here. Bagasse is sugarcane waste, what you are saying. Used in cardboard and paper industry. First time this was detected in cardboard industry workers. Nowadays seen in paper mills also. The fungus which grows on this sugarcane waste is that is thermoactinomyces. Thermoactinomyces is the fungus. Because of that, there is more chance of respiratory illness. And the prevention part is we have a fungicide, 2% propionic acid. This is acting as a fungicide to kill all this fungus. At the same time, one more thing what you are doing is moisture content. Moisture content, what they are keeping is more than 20%. The moisture content is more than 20%, the weightage of the waste will increase. If the weightage of the waste will increase, there is less amount of dust coming out of that. It will settle down. It will settle down. So moisture content more than 20%. And bagasosis is not a notifiable disease. Out of all this, if I am asking which is not a notifiable disease, it is bagasosis. Not notifiable. Not notifiable under Factory Act. Important. So one more last part what you should know is biomedical waste management. The last part what you should know is biomedical waste management, BMW. Biomedical waste management. So in biomedical waste there are 4 bags: yellow, red, white and blue. Yellow, red, white, blue. So many questions what they are repeating for you is on yellow bag only. Human anatomical waste they will ask, especially amputated limbs after surgery, placenta, like that they are framing a question. Swabs will be asked for you. Any swab like COVID patient, throat swabs you are taking, or any patient you are cleaning, swabs, and then what is being infected with blood and body fluids. Blood and body fluids. Cytotoxic drugs, important. They can give a vial for you, cytotoxic drugs. Chemical liquid, important. X-ray films, liquid waste, chemical liquid waste. Blood bags, used mask, N95 mask if you are using. All this will go in yellow bag. Yellow bag will do incineration. Yellow bag will go for incineration. Red bags. Usually what we say in red, we take the mnemonic as TRP. Tube, rubber, plastic. Tube, rubber, plastic. TRP. Tubes, rubbers and plastics. Tubes, IV tubes, catheters. All this will go in red bag. Urine bag red, blood bag yellow. Don't make mistake, blood will not go in red. So you cannot match it. Blood will not go in red. Remember like that. Urine also. Urine is yellow, you have to put it in red. Like that the students will remember. Urine bag it is red. Syringes without any needles will go in red. But syringes with needle will go in white. And again nitrile gloves will go in red bags. White translucent puncture proof containers are available for sharps, needle, fixed needles, blades and scalpels. All this will go in white puncture proof containers. Blue cardboard box, important. There are 2 things to remember: glass and metals. Broken glass or discarded glass, including medicine vials, but not with cytotoxic waste. With cytotoxic waste will go in yellow color bags. Without any cytotoxic waste, you can keep it in blue bags. And nails and metallic implants, especially in orthopedics, what you will be using. Nails and metallic implants, these will go in blue color bags. So repeat: yellow, red, white and blue. So most of the times questions are being asked again and again on yellow bag. So yellow bag is very, very important in biomedical waste. So this is the session, this is the session where I try to make it more concise for screening exams, FMGE exams. So based on the topics which are important in PSM. So I finished the session for you. So any doubts, if you have, you can inbox me in my WhatsApp number. You can follow me in the Instagram also. So I'll be giving some updates for you. So Rajeev Shetty, you can go to Instagram and you can follow me in the WhatsApp number. You can take, you can keep it. Any doubts, anything you want to ask, you can use my WhatsApp numbers also. 9971 916 548 548. So all the best for your exams. All the best for your exams. Best wishes. Anything if you want to convey or any doubt if you want to ask, you can use my WhatsApp numbers. Follow me in Instagram also. I'll be giving all the updates, question answer sessions, series in the Instagram part also. So thank you so much. Thank you so much.